Hi, everyone. Welcome to this JIPO roundtable on ESMO 2023 highlights from non-small lung cancer. Here with me co-hosting, I have Dr. Camila Braganca. Dr. Camila is a medical oncologist from Brazil and a PhD student at Hospital Sírio-Libanês in São Paulo and a current fellow of the Phase 1 fellowship program at MD Anderson Cancer Center Institute in Houston. We are honored to have with us Dr. Sewanti Limaye, the director of the Medical and Precision Oncology and Sir Ejanand Relax Foundation Hospital in Mumbai, India. Dr. Limaye did her fellowship in Oncology and Medical Oncology from Albert Einstein University in New York and worked as an attending in Medical Oncology at the Dana-Farber Cancer Institute and the Phase 1 Early Drug Development Center at Harvard Medical School in Boston. She is specialized in thoracic, head and neck, GI oncology, and early drug development, and will walk us through the highlights on non-small cell lung cancer from ESMO 2023. Dr. Limaye, we are honored to have you with us. Please, the screen is yours.
Thank you so much, Diogo, and thank you, Camila. Thank you so much for recording this session today. And thank you, JIPO, for giving us this opportunity. We are here talking today about the highlights of ESMO 2023.
This session will be divided in three main topics. We will begin with early stage non-small cell lung cancer, moving to the metastatic setting, and ending up with some key messages from ESMO 2023. So, Dr. Limaye, if we could, the screen is yours. Thank you very much.
Thank you so much, Diego. We will discuss early stage non-small cell lung cancer first. We'll begin with the ALINA trial. ALINA trial is an adjuvant alectinib in resectable early stage ALK-positive non-small cell lung cancer study where patients were taken with early stage non-small cell lung cancer that were ALK-positive, stratification between the stages 1B, 2, and 3A, Asian versus non-Asian population, randomization 1:1 between alectinib given twice daily for 2 years at the standard dosage versus platinum-based chemotherapy every 3 weekly for 4 cycles. And then the patients were followed for recurrence beyond that, every 12 weeks for the 1 and 2 years, and every 24 weeks for 3 to 5 years, and then annually. There was disease-free survival advantage seen in the alectinib arm. Disease-free survival rate at 24 months was 93.8% versus 63% and 88% versus 53% at 36 months. This benefit was seen across all subgroups with a hazard ratio of 0.24, ranging between 0.13 and 0.45. CNS disease-free survival advantage was also seen in the alectinib arm versus chemotherapy, and the safety profile was as expected from alectinib, and there were no surprises. Coming to the next landmark study that was presented in ESMO 2023 was CheckMate 77T. This was perioperative nivolumab plus chemotherapy in early stage NSCLC. We have suddenly seen avalanche of immunotherapy directed trials in early stage NSCLC, and this was one such seminal study presented. Resectable early NSCLC stage 2 to 3B were selected. The patients should not have received any prior therapy. No EGFR or ALK alterations should have been noted. Patients were randomized 1:1 between nivolumab plus chemotherapy versus placebo plus chemotherapy given every 3 weekly. Nearly 450 patients were randomized. Radiologic restaging was done after the neoadjuvant treatment, following which the patients underwent surgery. And after this, nivolumab versus placebo was given for a total of 1 year adjuvantly to these patients. Progression-free or event-free survival was seen. Advantage was seen in the experimental arm versus the standard of care arm. And significant difference was also noted in the pathologic complete response rates in favor of the experimental arm versus chemotherapy arm. Adjuvant nivolumab was tested against no adjuvant nivolumab, and in this we saw nivolumab plus adjuvant nivolumab. So neoadjuvant nivolumab plus chemo plus nivolumab in the adjuvant setting was the winner with significant advantage seen for the adjuvant application of nivolumab. And this advantage was most pronounced in patients who were stage 3 versus stage 2, and PD-L1 positive versus PD-L1 negative. Coming to the Keynote 671 trial with perioperative utilization of pembrolizumab in early stage NSCLC. Again, patients stage 2 to 3B NSCLC that had never received any previous treatment were randomized 1:1. Nearly 800 patients were randomized between pembrolizumab plus chemotherapy versus placebo plus chemotherapy. Chemotherapy was 4 cycles in each arm, followed by surgery, followed by pembrolizumab versus placebo to complete 1 year of post-surgical treatment with immunotherapy. This is the first trial to demonstrate overall survival benefit for perioperative application of immunotherapy, where we saw overall survival advantage seen in the experimental arm versus the standard of care arm, and a hazard ratio of 0.72 ranging between 0.56 to 0.93. And again, demonstrated in a large subgroup of patient population. The biggest beneficiaries were young males that were Caucasians and had current or previous history of smoking. This was also pronounced with high PD-L1 expression and those that were EGFR and ALK negative. The next study is EGAN, where we see the association of ctDNA clearance and pathologic response with neoadjuvant application of durvalumab. In this study, again, stage 2A to 3B patients were taken, never previously treated, ALK and EGFR negative, randomized 1:1, 800 patients were randomized, durvalumab plus chemotherapy, 4 cycles versus placebo plus chemotherapy, surgery done post neoadjuvant application, followed by adjuvant application of either durvalumab versus placebo. ctDNA was followed for prior to each cycle for all the 4 cycles, and pathologic complete CR and major pathologic response assessment was done. Additionally, post-surgery ctDNA analysis was also planned. ctDNA clearance was demonstrated during the neoadjuvant treatment, and complete pathologic response was also demonstrated higher in the experimental arm versus the standard of care arm. This brings us to the metastatic non-small cell lung cancer discussion. In this, the first that we will discuss would be Mariposa study. Mariposa study is the frontline application of amivantamab plus lazertinib versus osimertinib versus lazertinib alone for EGFR mutant metastatic NSCLC in the frontline setting, never previously treated patients. And the stratification was between the different kinds of EGFR mutation, Asian versus non-Asian race, and history of brain metastasis versus none. The primary endpoint was progression-free survival, amivantamab plus lazertinib versus osimertinib, and secondary endpoints were in the same population, overall survival, objective response rate, duration of response, PFS2, and safety. Progression-free survival advantage was seen across all subgroups mostly, and significant benefit in progression-free survival was demonstrated with lazertinib plus amivantamab versus osimertinib alone, with a hazard ratio of 0.70, ranging between 0.58 to 0.85. Mariposa 2 comes in with amivantamab plus chemotherapy with or without lazertinib versus chemotherapy alone in EGFR mutated advanced NSCLC patients that had progressed on osimertinib. A current arm of this trial is also testing modified doses of amivantamab plus lazertinib with chemotherapy versus amivantamab plus chemotherapy alone. And the endpoints were dual primary endpoint of amivantamab plus lazertinib plus chemotherapy versus chemotherapy alone progression-free survival versus amivantamab plus chemotherapy versus chemotherapy progression-free survival. The secondary endpoints were objective response rate, overall survival, duration of response, intracranial responses, safety in the same population. And a similar endpoint would be tested in the modified amivantamab dosing arm as well. The results of the current arms were presented at ESMO 2023, and there was a progression-free survival advantage seen in the combination arm with amivantamab plus lazertinib plus chemotherapy, winning the contest with an HR hazard ratio of 0.44. Amivantamab plus chemotherapy also showed advantage over chemotherapy alone with a hazard ratio of 0.48. And benefit was again demonstrated in all subgroups of patient population. When we look at the intracranial progression-free survival, both the amivantamab lazertinib plus chemotherapy versus amivantamab plus chemotherapy arms did better than chemotherapy alone. The safety profile was significantly noted for hematological toxicity, which is being addressed in the new arm of this study that is under testing. The next trial is Papillon study, which is a phase 3 clinical trial of amivantamab again, plus chemotherapy versus chemotherapy alone in the frontline setting in EGFR exon 20 insertion mutated advanced NSCLC patients who are treatment naive or locally advanced or metastatic NSCLC. They have documented EGFR exon 20 insertion mutation, and the stratification factors were ECOG-PS, history of brain metastasis or not, and prior EGFR TKI use in the adjuvant setting. The randomization was 1:1 between amivantamab plus chemotherapy versus chemotherapy alone. And the primary endpoint was progression-free survival with secondary endpoints of objective response rates, duration of response, overall survival, PFS2, and safety. Again, the amivantamab arm here, amivantamab plus chemotherapy, was a winner with progression-free survival advantage seen, hazard ratio 0.395, ranging between 0.3 to 0.53, and the benefit was demonstrated across all subgroups. PFS2 advantage was also demonstrated, and duration of response was superior in the experimental arm versus the standard of care arm. Then comes the Libretto 431 study, which is a practice-changing study of selpercatinib versus chemotherapy and pembrolizumab in RET fusion-positive NSCLC patients. Here, stage 3B, 3C, and stage 4 NSCLC patients that were RET fusion-positive via NGS or PCR were included. Symptomatic CNS metastasis was excluded from the study, and the stratification factors were East Asian versus non-East Asian, brain metastasis versus not, investigator's choice of treatment with pembrolizumab. 2:1 randomization was done with selpercatinib versus chemotherapy, where carboplatin or cisplatin was utilized along with pemetrexed plus minus pembrolizumab in the frontline setting. Optional crossover was allowed upon progression to selpercatinib for all patients. Primary endpoint was PFS, and secondary endpoints included efficacy, including duration of response, overall response rate, CNS responses, and overall survival. Safety and patient-reported outcomes were also included in the secondary endpoint. And here we see there was significant PFS advantage seen with selpercatinib versus chemotherapy with or without pembrolizumab, and the progression-free survival was seen in across subgroups, most pronounced also in Asians as well as patients with brain metastasis. Then comes in the Tropion trial, Lung-01, where we saw Dato-DXd versus docetaxel in previously heavily pretreated advanced metastatic NSCLC patients, where the patients could have received 1 or 2 lines of prior therapy. They could have had actionable genomic alterations or maybe negative for those, and they should have had no prior docetaxel for their advanced NSCLC presentation. The randomization was 1:1, and Dato-DXd at 6 milligram per kilogram was given every 3 weekly versus docetaxel 75 milligram per meter square every 3 weekly. The dual primary endpoints were PFS and overall survival. The secondary endpoints were overall response rate, duration of response, and safety. Here, we see significant progression-free survival advantage in the intention to treat population. This was seen most proficiently in the non-squamous population. In the squamous population, the advantage, the PFS advantage was not demonstrated, and the experimental arm actually was not found to be superior to the traditional standard of care of docetaxel. That ends the presentation of the early stage and the metastatic stage non-small cell lung cancer trials that were presented, prominent trials that were presented at ESMO 2023. Back to you, Diogo and Camila, for further discussions.
Dr. Limaye, thank you for this brilliant and concise presentation of the ESMO highlights. And for wrapping up, what key messages would you give out for early stage and for metastatic non-small cell lung cancer?
Thank you, Camila. For the early stage non-small cell lung cancer, we can see there are some practice-changing studies that were presented. The first study, the ALINA clinical trial, was a phase 3, which showed improved progression-free survival with 2 years of utilization of alectinib in ALK-positive early-stage NSCLC. The overall survival data still remains immature, but we have enough evidence today to look at application of alectinib in the early-stage NSCLC ALK-mutated patients. We need to wait to see additional overall survival advantage, but the PFS advantage being so significant would be practice changing. The second thing, which is the writing on the wall, is the utilization of immunotherapy all across early stage non-small cell lung cancer, which has now become very evident. With the presentation of Checkmate 77T, we saw perioperative application of nivolumab with chemotherapy in early stage NSCLC, where PFS advantage was demonstrated. But in the Keynote 671, we saw the perioperative pembrolizumab with chemo actually adding to overall survival advantage. So this was the first trial to demonstrate overall survival advantage in the perioperative setting. Of note, the patients who had higher stage and had a PD-L1 positive disease actually did better, and they had more advantage from the application of immunotherapy. Current and previous smoking history also added to it. Caucasians did better. So we need to take all these messages and select our patients carefully. The EGAN trial also demonstrated this with the surrogate endpoints of ctDNA clearance and enhanced complete PathCR, major pathologic response with application of durvalumab. So what becomes very evident is now for every early stage NSCLC patients, we really need to think immunotherapy and whether or not each patient that we examine in our clinic is a candidate for immunotherapy application or not. And obviously, the patients who did not benefit from the application of immunotherapy were those that were EGFR and ALK positive. So we need to exclude those patients carefully.
And regarding the metastatic setting, Dr. Limaye, can you walk us through the major breakthroughs and what you should highlight for this roundup, please?
So for the metastatic NSCLC patients, the space was owned by amivantamab. That's the new molecule on the block. And I felt all across it was amivantamab, amivantamab, amivantamab. So Mariposa 1 and 2, one where we saw improved PFS with amivantamab, lazertinib, osimertinib in the front lines versus osimertinib in the frontline EGFR mutated setting. So it does demonstrate the amivantamab lazertinib combination was better than osimertinib in the frontline setting for EGFR mutated patients. For Mariposa 2, we saw improved PFS with amivantamab, lazertinib, and chemotherapy versus chemo alone, or amivantamab chemotherapy versus chemotherapy in metastatic NSCLC post-osimertinib. The Papillons trial was also amivantamab. It showed improved PFS with amivantamab plus chemotherapy versus chemo in EGFR exon 20 insertion situation with advanced NSCLC. And the Libretto trial was a practice-changing trial because it brought forward the fact that there was improved PFS with selpercatinib vis-a-vis chemotherapy plus minus pembro in RET fusion positive metastatic NSCLC, bringing to the forefront the frontline application of RET inhibitors for this particular specific RET fusion positive advanced NSCLC patients. And then there was this new drug through the Tropion trial, Lung-01, where we saw Dato-DXd in comparison to docetaxel, enhancing progression-free survival in advanced NSCLC patients, specifically in non-squamous. So the message here through the Tropion was for non-squamous. There was no advantage seen in the squamous population. So we need to select our patients carefully in this particular patient population. And of course, when we come to the metastatic NSCLC, we cannot forget the FLORA-2 study that was just presented at WCLC, where we saw PFS advantage to osimertinib plus chemotherapy. So the metastatic NSCLC arena is enriched with amivantamab, with selpercatinib, with Dato-DXd, and the application of osimertinib plus chemotherapy in patient population. And now the challenges are with us to choose the applications of these therapies correctly, choosing the most appropriate patient, and patient selection would be most critical. So thank you. Thank you for having me. And I hope I was able to shed some light on the studies that were presented in ESMO 2023.
Thank you, Diogo. Thank you, Dr. Limaye. And on behalf of JIPO, I thank you all for watching our roundtable session, and we hope you enjoy it.
Thank you.